Good morning, everyone. So I'm going to be doing a little bit of a Heme Potpourri, which, by the way, someone told me yesterday they don't know what Potpourri is. So I feel super old, and I don't think I'm that old. But it's going to be sort of a mixed bag of a couple of things that are not going to get covered today topic-wise. Obviously, it's hard to cover every single Heme pediatric related topic. And one topic that I will recover because I think it's so, so important, okay? So for those of you guys that have never used Nearpod, can you go to nearpod.com and type in that code on the top left? And you should be able to, let me know once you guys are all done and we can get started. What?
Can you read it out?
Oh my goodness, Adam, you got your glasses on too. Okay.
It wasn't me, it was Harry.
Who also has his glasses on. All right, it's ATWRL. The number 8, TWRL.
Oh, thank you. I couldn't read it either.
Now we're just throwing people under the bus. All right, so I got people. Let me know if anyone's having any issues getting in. Bless you. Perfect. How many residents do we have? Like how many are we supposed to? 30?
There's like maybe 30 in the Zoom, and then there's.
And for all the Zoom people, are you guys able to log in? All right. David, you want to check the chat to see if anyone's having any issues? Sorry, I don't know. All right, we have 35. I think that's a good chunk of people. So let's go ahead and get started. Okay, so we're going to start with, it's not working. There we go. Okay, so let's go ahead and do the first question. So an 8-year-old male with severe hemophilia A presents to the ER with lower abdominal pain. Parents report that for the past few days, he's had increasing abdominal pain and is now refusing to walk. There's no history of trauma. On exam, he explains shooting pain down his right leg. What is the most appropriate first step in managing this patient? Oh. Well. So it looks like most of you guys have answered. So it looks like most of you guys picked B. So, all right. So let's talk a little bit about hemophilia, shall we? So just a couple of basics about hemophilia. So hemophilia A is a X-linked recessive disorder. So it's associated with a decrease in factor 8. And then the end goal of all treatment for any child with hemophilia is to raise the factor level to a sufficient enough level that they're able to achieve hemostasis. The goal is always to stop the bleeding. So the most common types of bleeds in hemophilia are going to be hemarthrosis. So this is, for those of you guys that have seen your hemophilia patients, commonly they'll come in, kids, they'll come in with knee bleeds because they're constantly falling. So hemarthrosis are generally the most common. But the other thing to always kind of remember and keep in the back of your mind that's not necessarily as obvious is going to be bleeding into the muscle. Just because you tend to have a little bit more space before you start to have presenting symptoms. So in our case, in this question, this child was actually having an Iliopsoas hemorrhage, which is an emergency for a hemophiliac. So, well, did you guys see that? All right, fine. So the most common areas for bleeds for hemophiliacs are going to be CNS bleeds, right? That's always like the biggest concern is when they fall, do they hit their head? Just because the risk of bleeding, you're always going to think about CNS bleeds. Ocular bleeds, deep muscle bleeding, like in this case, especially because it sets you up for potential for neurovascular compromise, essentially like a compartment syndrome, without maybe an obvious source, because they may not present as kind of like, hey, this is exactly what happened. I fell on my thigh, and they're going to present with maybe a limp and something very sort of subacute. Bleeding that could affect the airway, right? So bleeding into the throat or neck. And remember that any bleeding severe enough to result in anemia requires RBC transfusion along with your factor. And a lot of times, you know, they'll have like a home-based, they'll have their medications at home, sometimes that they'll bring it in, but things like Iliopsoas bleeds are all call for factor immediately and call hematology. And if you're concerned that they're anemic, just go ahead and order the blood, because you'll never be wrong to transfuse. You can always stop the transfusion, but you can't always take it back once you've waited. So anybody know what our closest hemophilia center is? No? So it's actually Mount Sinai. So one of the things that's different maybe about New York, so if you go to say like the Midwest, usually the tertiary and quaternary care centers, there's always one major children's hospital that's your hemophilia center, your cardiac center, your sort of center of all things. New York is a little bit different because we have so many major institutions, and everyone sort of kind of has a stake or claim to something. For us, Mount Sinai in the city is our hemophilia center. It is where a majority of our hemophiliacs are seen, are followed. So sometimes you will get them here because they are either new and they haven't established care yet, or because they didn't have time to get to their center and EMS brought them here. So for the most part, if you're ever unsure about a patient with a bleeding disorder, you can always call Sinai and have them look up the patient for you. They're always generally more than happy to kind of give you advice.
The LIJ also, Cohen Children also.
Yes.
Patient.
Yeah.
So if they're on the border to come this way.
Yeah.
They also have a listing of their patient.
Yeah, sorry, I forget about LIJ because so many of our patients don't have cars, so my brain sort of automatically goes to the hospitals in the city, but LIJ is also another place that you could transfer if the parents and families are interested, so you can offer either one. So let's talk a little bit about why these other kind of options are wrong. So obtaining a CT scan of the abdomen and pelvis or obtaining an ultrasound, either imaging modality is reasonable to try and figure out where the hemorrhage is. So you can theoretically do either. However, imaging is not going to be the first step in your management. If you have a hemophiliac, you're concerned about bleeding, the first step is always going to be to treat the problem, and then you can always image them later. So especially because Iliopsoas hemorrhage in this case has a really high potential for a massive bleed because there's a lot of space there that the blood can really sit. So you must treat it like a life-threatening condition because that really is what it is. Especially in Iliopsoas hemorrhage that is presenting with symptoms, like in this case, you have to assume that they've probably been either bleeding into that cavity for a little while, or there's a lot of blood that has been lost for them to actually have symptoms from it. And so you got to order the factor. In our case, bless you, in our case at Kings County, so when you call the blood bank to order factor, they may have you call hematology to confirm that they need the factor. Our pediatric hematologists have never taken more than 5 minutes to ever call me back. So if you're ever concerned that that's an issue, please let us know like in real time, because this is a real time problem. But for the most part, the blood bank, if you're unable to get in touch with them, will release factor to you without any issue. So that's your iliopsoas, that's your iliopsoas, and that's sort of where the bleed is. Anyone know what the other sort of signs and symptoms of iliopsoas hemorrhage are? No? Okay. Well, I'm glad this is a new topic that, so classically they'll present with lower abdominal pain. And I know that, in kids, when we think lower abdominal pain, our sort of mind automatically goes to the surgical stuff, like your appies and your peritonitis and, in females, your ovarian issues. So one of the things that, we should ask is, is there any history of bleeding or easy bruising? Or if you see a kid with a lot of bruises, ask if there's any concern for a bleeding disorder. Usually parents will know, because by the time they present to you after a couple of years, they probably had a few bleeds. So they will know. The other thing is flexure, contracture at the hip, right, is another kind of common presentation. Sometimes this can be confused in the right setting for, you could be concerned for like maybe a fracture, because maybe the parents will give you something like, hey, he fell. So just sort of always keep it in the back of your mind. And then the paresthesia radiating down the lower extremities, which is what our kid had in this question. Okay, perfect. So let's go through the other answer choices. So, for aminocaproic acid, it's an antifibrinolytic and a hemostatic agent. It inhibits fibrinolysis. There's no real contraindication. It's an adjunct therapy. It's not the primary therapy, and it's definitely not your first line of management in someone with hemophilia who has a bleed. And if I haven't said it enough times already, give the factor. And then, so how to assess whether the bleeding has stopped? So this is always sort of one of those things with the kids with hemophilia that can be a little bit tough. So there's no real slam dunk way to say, okay, you're give factor and you're great, you're no longer bleeding. You can check repeat H&Hs, you can reassess pain. So it's literally going to be a little bit more of a kind of holistic approach. And if you're ever concerned, that they're continuing to bleed, you can always give more factor. But for the most part, if you have to give factor to these kids, you should probably be admitting them for observation. You should generally not, these are not the kids that should be going home after getting factor, just because of the risk of bleeding. And also the problem is that you can't, there's no slam dunk way to say the bleeding has stopped. So you should always err on the side of caution given their history. So what do you do if the bleeding doesn't stop? Also, no right answer. You can always give more factor, talk to your hematologist. If there's a joint involved, you can get ortho involved. They can consider an arthrocentesis, although it becomes a little bit dicey because you also don't want to do invasive procedures that can cause bleeding. You can consider TXA. So there's a lot of talk about TXA. There's very little data with TXA and pediatric patients in general, but I don't think there's anything for TXA and hemophilia. You can consider the TXA if you're unsure the kid is, not doing well. Just give it. You probably have nothing to lose at that point. But just don't give TXA and then aminocaproic acid at the same time. It just increases the risk of thromboembolism. But like I said, there's no studies, at least the last time I checked, with TXA and hemophilia. So true or false? Diagnostic X-rays provides no significant clinical information in hemophiliacs without a history of trauma.
Yes, false.
True. Right? So spontaneous hemorrhosis are common in patients with hemophilia. X-rays just document chronic changes in acute effusions, neither of which will aid you in the management of these patients. So I'm going to say it one more time. There's no imaging that you should use as a clinical diagnostic factor in someone that's a hemophiliac that you're concerned has bleeding. Give the factor. Don't wait on the imaging. Yeah? Okay. True or false? Use the patient's own medication when possible. True, yeah. So absolutely. So a lot of patients, not a lot, many patients that come in that are hemophiliacs will have a supply of their own condition-specific factor. Usually it'll come with instructions on how to mix it for the nurse. It's usually fairly easy. Using this factor will actually reduce errors because you know exactly what they need to get, you know how to mix it, it's already written down. And it also minimizes theoretical risk of increasing the inhibitors with that can happen with the change in the brands of the factor. And also, I'll be honest, the last hemophiliac we had in the ER, as quickly as we want to get factor, everything takes time, right? Nothing comes instantly in the ER. It comes the quickest here, but nothing comes instantly. So it still takes a little bit of time. So if they come with their own factor, please go ahead and give it. All your hematologists will tell you to go ahead and give it. And if you're ever unsure, you can always call whatever center prescribed it to them. They always have hematologists on call, and you can confirm that this is the dose, this is how much to give, this is how to give it. And sometimes making that phone call is quicker than waiting for the factor that you have at your own institution. Okay? All right. Any questions about hemophilia? Yeah.
One comment, the presentation for hematoma can also mimic appendicitis. So when you've got pain, you gotta make sure that you're not but you have other conditions.
Yeah.
And then just real quickly about hemophilia, someone will tell you to correct 100% or correct 50%, but they're telling you the calculation is how much factor to give. So if it's a major bleed into a muscle in the head, it's a fall, you're gonna correct 100%, and then the patient can be discharged them, or let them go home and also correct for the next couple of days. But those words, if you've never heard them before, can be really weird. You're like, correct what?
Yeah, no, that's a really important point. If you're ever in a situation where you have a patient with hemophilia that comes in where you're concerned about an iliopsoas bleed, they're coming in with right lower quadrant pain, and you're concerned that this kid maybe has an appy also, but is also bleeding. Bleeding gets prioritized. Fix the factor. You can always give antibiotics, and you can do your imaging later. But nobody's going to take this kid to the OR if he's a bleeding risk, right? So you can't do anything about that appendicitis without fixing his the bleeding disorder. Adam.
Will the iliopsoas bleed be peritoneal? Like when you're palpating the abdomen, will they have rebound? Will they have other signs that make you think closer to appy?
So, no, go ahead,
They
Amber.
might have a psoas sign if they're bleeding into their psoas.
Right. So they're gonna get comfortable. You're not gonna go because
Okay.
they're gonna have so much pain. You're not gonna do
Cool.
Yeah, and I think that's the thing is that you just don't know, but you know that they have this condition, so you assume that this is the problem because that is the bigger problem to fix first. So you fix the bigger problem, and then you can get to your secondary and tertiary problems. Fair enough? Okay, so question 2. Okay, so 6-year-old with AML who last received chemotherapy 2 weeks ago presents with fever and abdominal pain. Temperature is 38.4, heart rate is 130, rest with 24, and a blood pressure of 102/60. On exam, he's mildly ill appearing, has moderate abdominal distension and diffuse abdominal tenderness, especially in the right lower quadrant. His CBC from oncology clinic yesterday showed, so I think you guys can see the full question, right, on your screen? Perfect. So you guys could read the rest because I can't see it on here without going to the answer. Let me actually log into my own presentation. So you guys can go ahead and answer whenever, once you've read. 50% of people waiting. Okay. And 20% hold out. Okay. All right, so this is pretty good. So before we actually get into what the answer is, does anyone know, not our Pem fellows, because I think you guys have probably seen this question, but does anyone know what the diagnosis is? Because you have to know the diagnosis to figure out what you're treating. Say that again?
Is it neck?
It is not neck, but it's something very similar to neck. So it's great. So let's talk about it. So the answer, what did you guys pick? I forget. The A, right? Perfect. So Mr. Cefepime and metronidazole. So this patient actually has Tephilitis. How many of you guys have actually heard of Tephilitis? Okay, good. So Tephilitis is essentially, the way I think about it, is neck in a cancer patient. It's sort of the kind of crude equivalent of what Tephilitis is, but essentially a Neutropenia Colitis that is a life-threatening infection. It's most commonly seen in patients with sort of advanced hematologic cancers, and it presents like an appendicitis with periumbilical pain, right lower quadrant pain. They are generally fairly ill appearing. And your most common thought is always going to be this patient probably has an appendicitis, except that, they're being treated for some sort of malignancy. So generally, they get their cytotoxic chemo that causes mucosal injury and neutropenia. And they already have sort of impaired host defenses, right? So, and essentially causes translocation of the bacteria through the bowel wall. And then you can get a transmural bowel wall inflammation. So, and necrosis as well. So it's essentially, like I said, think about it like neck in a cancer patient. It's sort of the same process. So the management is going to be, as you guys chose, antibiotics ASAP. Generally you want to cover your gram negatives and your anaerobes. This I'm sure you guys will hear, but always do antibiotics first, and then you can always consider imaging or CT scans, which can be diagnostic. And in terms of ultrasound can show features of Tephilitis, but there's a much higher false negative rate than a CT scan. So in someone that has right lower quadrant pain, that's someone that has a malignancy that's going through chemotherapy, go to the CT scan first, because it's probably going to give you your diagnosis quicker than your ultrasound will. And then surgical indications, generally the treatment for this is antibiotics, except if they have signs of intestinal perforation, or if they have uncontrollable coagulopathy or acidosis secondary to the bowel necrosis. All right, so any questions about Tephilitis? Yeah?
But could you, with just the x-rays, see the pneumatosis intestinalis and say that's it?
So in theory, yes, you could, but it's not as good as a CT scan. And this is a diagnosis that if you're gonna do it, you wanna try to make it as early as possible. So you would probably get your CT. Now, if you wanted to get a portable x-ray because you're concerned about bowel perforation, I think that's absolutely reasonable. But if you're not concerned about bowel perf, I wouldn't prolong getting a CT scan to send them to x-ray. Because getting a negative x-ray doesn't mean they don't have Tephilitis. Make sense?
Usually these kids will also have really intense abdominal pain.
Yeah.
And so you are treating them like an acute abdomen, even though they might not necessarily be peritoneal, but you'll put them in PO.
Yeah.
You'll give them antibiotics. You'll probably end up, depending on where you are, consulting surgery or not, depending on how comfortable your diagnosis is. But most institutions, because these children, for the most part, are inpatient at that point, the chemo has gotten them so neutropenic, they're still inpatient. It's a diagnosis made by inpatient, which means usually they'll wait for an MRI versus a CT if you're concerned about radiation. So that is also an option. But for the most part, the clinical management is the same. And so you're giving the antibiotics, you're making them MPO while you're waiting for better imaging.
Yeah, I think the caveat with the Tephilitis is that our brain always goes to API whenever you have right lower quadrant pain, because that really is the most common cause of surgical right lower quadrant pain that we see. So it's not an unreasonable first thought. And so our reflex, at least in pediatrics, is let's go ahead and get an ultrasound if we don't think they're perforated, and then we can sort of work our way to a CT scan, assuming that this kid is not actively decompensating. So that's sort of the one differentiation that I want you guys to make in the back of your head is if you're thinking an epi in a kid that has malignancy that's getting chemo, don't do the ultrasound, don't sort of wait on it, just do the CT first, because the risk of badness that happens with tephilitis is worse than the risk of radiation with the CT scan. Yeah.
If like a kid is like in a lot of pain and they're like breathing and like moving around, how do you get them to stay still enough for the CT?
Morphine.
Okay, so how much would you do?
So 0.05 to 0.1 mg per kg of morphine. You can also do intranasal fentanyl, which we have in our ER. And if you really need to, you need to sedate them to get the CT scan, you can go ahead and do that. But for the most part, if you pain control pretty well, they should be okay. But of course, if you can't get it, it's still a surgical diagnosis in the sense that if you absolutely can't get your CT scan, but your pretest probability is high enough, you're still going to treat with antibiotics, assuming that they're not perforated. And then you can always kind of go from there. It'll be more of a clinical decision, but you definitely, just the same with your appendicitis kids, you want to do pain control because it's going to make everybody's life. There's no reason to allow these kids to be in pain because you're doing all the management anyway. Okay. And for those of you guys that don't know, intranasal fentanyl dosages are in the pink binder in the Kings County ER. If you guys haven't looked at it, just take a look at it. All the doses are there for intranasal fentanyl, intranasal Versed, intranasal Presidex, and ketamine? No. Yes, I forget what the fourth one is. I think it's intranasal ketamine, but it's all there. So if you're having a hard time getting a line because the kid is so wriggly, give the intranasal fentanyl first. It works wonderfully. It makes everybody feel better, and you can kind of grab your line after that. Okay, cool. Any other questions? No? Okay, cool. So let's keep it moving. Question 3. So a 5-year-old previously healthy female presents to your ER after falling onto her left arm while jumping in an inflatable bounce house. Her vital signs are normal and her exam is significant for tenderness and swelling of her proximal upper extremity. You can take a look at her x-ray. What would you guys do for management? Also, I think you guys can zoom in on the picture.
Yes.
Yes?
I
Okay.
could click it.
Perfect. So we'll give it another 30 seconds. We still have about 40% of people. So, bless you. All right, so we got 20% of answers, so we can go ahead. So most of you guys chose A, admit first surgical resection. Does anybody know what the diagnosis is?
The summers. So it's an osteosis.
Okay, so the answer is actually immobilize and recommend serial outpatient radiographs. So let's talk about it, because what you guys chose is probably the most common answer for this condition. So what this patient has is a UBC, or a unicameral bone cyst, okay? So it is a pathologic fracture. I'm sorry, there's a lot of patients that are like, what is that? So it's not particularly uncommon. I had one maybe a couple months ago. So also presenting with a pathologic fracture. So it is, they'll essentially present with a pathologic fracture of wherever the UBC is, but it is considered a malignancy without requiring chemotherapy as the initial management. It's sort of considered a benign malignancy. I know that's a bit of an oxymoron, but sort of think about it in that way. It's most commonly found in your proximal humerus, and the most common presentation is, they'll sort of trip and then they'll hit their arm on the side of the wall, or sort of very trivial mechanism for the presentation, and you'll get an X-ray and you'll be like, wow, I did not see this coming. The kid that I had a UBC actually had essentially that he was playing and he, ran into the side of the wall, and mom was like, I don't understand how you can run into a side of a wall and get a fracture. And he ended up having a UBC. So very sort of trivial mechanism is sort of the thing to remember. So the lesions are benign and they require mobilization acutely for the fracture. And chronically to protect the bone from sort of further injuries, just because there's risk of fractures. And resolution can take years, but given the benign nature, they almost universally resolve. There's really no need for chemotherapy or emergent surgery in any of these, unless you're concerned that there's neurovascular abnormalities. That's a different story. That's an orthopedic emergency. But for most of these, they won't have that. And surgical sort of management is rarely required. Occasionally, if they're non-resolving after many, many years, they can do curettage and bone grafting. Essentially what they do is sort of scrape the inside of the bone that activates the bone matrix to help regenerate the bone. So for those of you guys that chose, another question. So for those of you guys that chose the chemotherapy option, the reason that is wrong is because if you, so I didn't put up any pictures of what a sunburst pattern looks like on X-ray, but it really does look sunbursty on X-ray, which is not the case here. Also, if you do end up doing labs on these kids, they'll be fairly unremarkable, and they'll sort of be very well appearing. So most of these can be managed outpatient. Okay. Any other questions? No? Yes.
Just so in an adult, sometimes you will see pathological fractures, not commonly. That's the most common. Sometimes you'll see sarcomas, osteogenic sarcomas. I had a case a few years back, pathological fracture on someone on dilantin, which can affect the bone.
Yes.
And they came in with trivial trauma, but they were complaining so much. I got an X-ray, and they had a pathological fracture. Turned out the only underlying cause we found was they were on dilantin.
Wow, that's so interesting. I had no idea. Cool, thank you. Yeah, any other questions? No? Well, good. I'm glad I'm covering topics that are new to you guys. All right, question 4. I put this in here. I know Christina just did her presentation, but I think it is so important. So I put in a question in here about something she talked about. So 17-month-old boy is brought to the ED with a fever. It's a history of sickle cell SS disease. He has no history of sepsis or bacteremia. His vital signs include a temperature of 40.5, heart rate of 176, a rest of 28, and a blood pressure of 90/60. He's satting well and he's tired of hearing. You can see his laboratory findings. What do you guys want to do? Got about 50%. another 30 seconds, okay? I need you guys all answer. Yeah, that 30% is really holding out. Are these the Zoom people? All right. All right, this is pretty good. Only 25 people haven't answered. So, perfect. So you guys picked ceftriaxone and admission. Excellent. Can someone tell me why you guys chose C over D? Huh? Yeah, what's wrong with the white count?
Just about 30.
Yeah, What else? I heard whisperings.
Fever.
Someone said fever more than 40. Yeah. So I know we just talked about this, but I think it's so important because we get so many kids with sickle cell disease and fever in the ER. And a majority of them will go home, but it really, really is so important for you guys to know the high risk patients. So these patients are functionally asplenic, their risk for invasive bacterial infections with encapsulated organisms, and fever should be promptly treated with ceftriaxone. For those of you that don't know, also there's a sickle cell fever pathway also in the pink binder in the PEDS-ER. So any patient with sickle cell and fever, please refer to the pathway to know what labs to order, how much medication to order. And despite penicillin prophylaxis, which is generally standard of care until they're about 5 years old, and pneumococcal vaccination, the risk of invasive bacterial disease is still pretty significant, which is why we antibiotics not almost all of these children that at least come in. So the high risk factors are the ones that like I said, really wanted to highlight because it's so important. So obviously an ill appearing child, but temperature more than 39, age less than 1 year, white count more than 30, less than 5, obviously a history of sepsis or bacteremia, and lack of reliable follow-up. I know we just sort of talked about this, but I can't highlight this enough because yes, Tephilitis is important. Yes, hemophilia is important, but this is something that you will probably see once a shift. So this is something that you really, really, really have to know so well. Okay. So just memorize this and put it in your brain. And if you can't memorize it, we have a pathway in the pink binder. Okay. Is anyone unsure about where to find information in the PEDS-ER? Huh? All right, next question. So you got a 65-day-old term male infant transferred from a community ED for poor feeding and fussiness for 1 day. He was born at home, no complications, is unvaccinated, and mom has not given child any home remedies. He was breastfeeding well. Until the day of presentation. Mom denies any URI symptoms or vomiting. On exam, he's well nourished. He's afebrile. Pulse of 174, rest of 28, blood pressure 78/56, satting 97% on room air. He's fussy with a full fontanelle. He's got symmetric facies, a strong suck, and good grasp. Is moving all his extremities well. His heart and lung sounds are normal. His abdomen is soft, non-tender, no organomegaly, and no skin rash or no signs of jaundice. Before his transfer, blood and urine cultures are performed and a CT head is shown, which you guys should be able to see. And a skeletal survey is completed magically at this community ER and normal. Of the following, which would be the most helpful in confirming the diagnosis? Oh, yes, it is
One
fast. Oh, yeah, go ahead.
Oh, I was gonna say A is fast, B is MRI, C is INR, and then G, I think, was like more
CSF studies.
CSF stuff. Okay, great.
glad no one's doing a tap. That's excellent. All right, we'll wait another 30 seconds. Okay. Perfect. So it looks like most of you guys chose C, which is PTINR. Can someone tell me what the CT scan finding is? Perfect. Someone tell me what the diagnosis is?
Vitamin K deficiency.
Yes, vitamin K deficiency. So, perfect. So let's talk a little bit more about this. You know, we didn't really talk about it that much for a while because not that it had gone away, but the cases were far and few, but not as much anymore. So vitamin K deficiency. So the infant in this vignette has a large subdural hematoma resulting from a severe coagulopathy because of vitamin K deficiency. And the answer is going to be an elevated PT and INR, which would be the most useful test to kind of figure out the diagnosis. So let's talk about why the other questions are wrong, and then we'll kind of come back to why a little bit more about the hemorrhagic disease of the newborn. So FAST is going to be for a trauma and could be performed, but it really is low utility in infants. You know, if this kid has signs of blunt trauma, a CT scan would probably be a lot more useful than a FAST. An MRI would be more useful in a kid that you're suspecting a stroke, not so much in someone that you already have sort of an established diagnosis of a bleed in. So not really particularly helpful. And then, yeah, please don't tap anybody that has a bleed. I don't think we need to delve too deep into that. Or not just someone with a bleed, or also someone where you're concerned about a bleeding disorder, like a bleeding issue, okay? don't tap them. So let's talk about vitamin K deficiency. So, you know, unfortunately, vaccine refusal rates have more than quadrupled in the past decade or so. Vitamin K is a cofactor in the production of multiple clotting factors, including protein C, protein S, and a bunch of the factors. So neonates are at the highest risk for vitamin K deficiency for a couple of different reasons. So vitamin K is primarily produced in the gut, and they have a fairly undeveloped gut in neonates. And it passes poorly through the placenta, so doesn't really come from mom a whole lot. Breast milk contains very little vitamin K on top of that, so even more concerning in someone, particularly in this patient that is exclusively breastfed. And maternal medications that could interfere with vitamin K, like anticonvulsants, TB therapy, can also place newborns at risk. It can occur generally in early infancy, sort of, I think, how most of us think about it, but doesn't always have to be in early infancy. In this case, this kid was, I think, 60-something days, if I am not mistaken, 65 days old. So generally, early vitamin K deficiency is generally seen the first 24 hours after birth, and usually for maternal medications and severe hemorrhage and things like that. Classic vitamin K deficiency usually presents sort of the first week after birth in neonates who haven't received prophylaxis and who are exclusively breastfed. So, you know, all kids that are born, for those of you guys that don't know, get something called eyes and thighs. So they get erythromycin in the eye and they get a shot of vitamin K in the thigh. So if you hear that, that's, you know, I feel it's like a common peds thing, like, oh, did you get your eyes and thighs? Like, that's what they're talking about. But late vitamin K deficiency generally occurs, as in this patient, between 2 to 8 weeks after birth, but can occur even later. Usually presents as intracranial hemorrhage in an otherwise healthy infant with no history of trauma. Obviously, you don't know that for sure, but in this question, they were telling you that a skeletal survey was negative, and that's sort of what they're telling you, that this is not trauma, so don't go barking down that tree. And prolongation of the PT-INR and PTT if the deficiency is really severe. Platelets and fibrinogen are generally normal. So the treatment of it is going to be 1 to 2 milligrams of vitamin K with intravenously with correction of the coagulopathy and about 2 to 3 hours of administration. What about because vitamin K is given IM when they're born? Is there any reason you can't give it IM if they're actively bleeding? I hear whispers. Anyone? I know you guys know this.
Could you possibly have like a muscular,
Absolutely. That's exactly why. So that's a rule of thumb for all patients. So even your hemophiliacs, you want to avoid giving IM medications because they can just form a hematoma there because they're not clotting, right? So this goes for vitamin K deficiency patients as well. So you want to avoid it because of hematoma formation. What about PO vitamin K?
It has to be, it's like more than one dose, like it has to be dosed over multiple weeks. So you could give it theoretically, and they do it for people with like Coumadin overdose and other things. But it takes for like multiple weeks to treat it. It's not going to happen very quickly.
Okay. So oral vitamin K prophylaxis has much lower efficacy than IV or IM in preventing particularly late disease. It has less desirable than IM administration. However, in patients in families that are maybe hedging or they're really anti-IM vitamin K, it is sometimes given as a PO because the thought is that, yes, it's not as good, but something's better than nothing if you're going to get absolutely nothing. So if you are concerned about a patient with vitamin K deficiency and bleed, ask the patients, hey, did your child get a shot of vitamin K or did you choose to get the oral vitamin K? It might give you a little bit of insight into kind of maybe they're just not adequately sort of medicated with vitamin K. But theoretically you can, and I have seen it been given for patients that are particularly anti-IV IM medications. But it's obviously given with a lot of like, hey, these are all the issues that can come because of it. And then FFP is indicated for severe active bleeding, which you guys know. So a couple of anti-vaccine thoughts about why people maybe refuse this. There's, gosh, it makes me so crazy. But so it's been cited as a danger by anti-vax groups because of the suggested link to later childhood malignancies. But interestingly, almost no families that refuse vitamin K will tell you that. They just refuse because they don't believe in vaccination and they believe in natural medication. So anyway, so if that ever comes up, it's a conversation to be had. Yes. Yeah, go ahead.
So, even IV vitamin K in adults who, let's say, have a Coumadin overdose, that will take sometimes hours. So if they're really bleeding, like you said, you could use fresh frozen plasma. What we use more now is PCC.
Okay.
And that works much quicker.
Much quicker?
The 4-factor component is what we'll use. And that'll work within minutes, whereas vitamin K may take up to 8 hours.
Oh, that's so interesting. Maybe we can look up to see if there's any recommendations for how much do you give? Is there a dosing recommendation?
Yeah, that's a dosing recommendation.
Okay.
It's online and you can do it. You can look it up as reversal of Coumadin.
Coumadin, yeah.
Right, but you got to get both because in the long run you need the vitamin K, but that just takes hours. So you use PCC, or if you don't have PCC, you can use fresh frozen plasma. The problem with fresh frozen plasma is you got to give a lot of it.
You got to
give a small person or someone with CHF or renal failure, you probably would want to fluid overload them.
Yeah.
So we use now more and more. We use the PCC, the prothrombin complex.
Yeah. Rosie, do you think you can look up to see if there's any studies of PCC being given in neonates for this? And
I'm trying to look it up right now.
Yeah.
I know we've definitely given vitamin K IV inpatient to patients with coagulopathies, especially our liver transplant patients.
Yeah.
But I will look at that PCC.
Yeah, Rosie will email it out, but that's really interesting. I've always classically been taught vitamin K and then FFP if they're actively bleeding. But yeah, we'll look it up. It's great. Thank you so much.
And the other thing about vitamin K when you give it IV is sometimes people have had anaphylactoid reactions. You don't want to bolus it in, but you can give it in as a fast drip,
Faster, yeah.
in adults at least.
I think it's the same for kids. I mean, I've only had one patient a long time ago. I think this is when I was like a med student. So I don't really remember sort of the details, but I do remember something about an anaphylactoid reaction. Yeah. Cool. Any other questions? No? Okay.
Oh, it doesn't look like it says they're using it for adults, but currently evidence is only anecdotal for pediatric patients.
Okay. I think that's one of the tough things, especially with neonates, is once they get to sort of that teenage age, you can essentially dose them as adults for life-threatening things. But it becomes complicated with neonates because you don't want to fluid overload them, and then you just don't know how much to choose. But we'll keep an eye out. That's
Yeah, we'll see.
Adam, go ahead.
Are there any states where you're not allowed to perfuse vitamin K? Because I was speaking with someone about it. Someone said to me, I don't know who it was, but they said to me there's at least one place that you remember where you can perfuse Hep B, but you couldn't perfuse vitamin K. And I don't
Not
know
that I know of. I'm sure a quick Google search would tell you that, but not that I know of. I think you can, I don't know. You can look it up and let us know. David, do I have time for one more question or am I going over?
Yeah, you're
You
good.
got time.
Time? Okay, perfect. So we'll do one more. And any other questions about, but no? Okay, cool. So I think this is the last question. So we have a 18-month-old presenting to the ED with 3 weeks of fever, rash, and decreased activity. She's been seen by her PCP in several urgent care clinics over the last 3 weeks. On physical exam, she's febrile and tachycardic, but otherwise normal vital signs. She is listless. She has a diffuse erythematous maculopapular rash, mild splenomegaly. Blood cultures and EBV titers from her most recent visits have been negative, but her labs today show a hemoglobin of 7, platelets of 65,000, an AST of 360, and ALT of 200. Which of the following additional tests will be the most supportive in diagnosing her condition? And the options are decreased albumin, elevated CRP, elevated ferritin, low serum triglycerides, and elevated fibrinogen. Wait another 30 seconds and then. Hmm. 30% hold out. All right, let's, in the interest of time, all right, one other person got in. So it looks like most of you guys chose elevated ferritin, and the next is going to be elevated fibrinogen. So does somebody know, before we get to the answer, what what's going on here, what the diagnosis is?
I'm not sure.
Okay.
I had thoughts, but I'm curious to see what other people's thoughts are first.
Okay. Other people, what are your thoughts?
I was thinking HLH, but
Yeah, so yeah, good job, Liv. All right, so this patient has HLH. How many of you guys have heard of HLH? You guys have, okay, all right. The attendings don't count, y'all. All right, so HLH is a life-threatening syndrome of excessive immune activation. It causes tissue destruction and inflammation. So the NK cells, they sort of fail to eliminate the activated macrophages. This sort of lack of normal feedback kind of results in like excessive T cell activation, macrophage activation, and sort of really high levels of interferon gamma and other cytokines. So it's essentially a cytokine storm, which, have we seen it with something else recently? So it's most commonly HLH is seen in infants and toddlers, and it's associated with really common childhood viral infection, nothing super special like EBV, CMV, parvo, stuff that we sort of see super commonly. And most recently, it's been associated with COVID. So symptoms are going to be sort of a subacute febrile illness. It's associated with essentially multiple organ involvement and sometimes multiple organ failure. It presents very, very insidiously. It's, you know, it's a little bit tough now in this environment because I think, not just this environment, but most pediatric patients present with fever and maybe a little bit of irritability. So one of the sort of the things that separate this from your regular illness is going to be generally fever of unknown origin. It's usually going to present for a prolonged fever. This is not going to be generally your fever for 1 of 2 days, except if you have someone with organomegaly. So your kid with hepatomegaly, your splenomegaly, diffuse lymphadenopathy, obviously neurological symptoms like seizures, altered mental status. A rash is a classic sort of part of the presentation, but there's no one particular rash that it is associated with. So diagnosing this can be really, really hard, which is how it generally happens is that they've generally seen multiple providers over 1, 2, sometimes 3 weeks. And it's sort of just been going on. The kid's just getting sicker and sicker and sicker and sicker. So this is always one of the things to consider if you have a patient. I know one of the things that I always try to do is anytime you have a patient that says, hey, I've been to 2 urgent cares, I went to my PCP, I went to Brookdale, and I went to wherever else, and they keep telling me my kid's okay, but I just feel like the kid's not okay. Always just, whenever you have a patient like that, just take a step back. You want to try and do something different and think about something different compared to what everyone else has done. These are the kids that'll have something weird that may not be your sort of instant, hey, you have a URI that's going to get better diagnosis. So labs are generally concerned with anemia, thrombocytopenia, with or without neutropenia, but sort of the classic finding in this is going to be an elevated ferritin. It's one of the distinguishing sort of lab results that'll help you separate it from malignancies, like blood malignancies. And HLH and MAS or macrophage activation syndrome are sort of a continuum is how you should sort of think about it, but they're very similar in their presentation, but you want to think of MAS as HLH plus some sort of rheumatologic disorder is sort of how I delineate it. But it's essentially thought to be a form of HLH. The management kind of can be a little bit different, but it's far more nuanced than what we need to know in the emergency room. We just need to know to think about this diagnosis and to order the test that'll help us lead us to the diagnosis and then kind of go from there. So management, call your hematologist or your rheumatologist, one of the two. If you have a kid with, say, like JIA that's presenting with these symptoms, you should probably call the rheumatologist. If you have a kid that doesn't have any rheum condition, you can call the hematologist. But, you know, step one for any of these is going to be you want to kind of suppress inflammation, which is what's actually doing all the damage. And dexamethasone, and for the ER, Dex is probably going to be your first line treatment. Once they get admitted or for further workup, they sometimes can get induction therapy with the Dex and the etoposide. They can also get intrathecal methotrexate, hydrocortisone, especially if they have CNS disease. And usually after induction, patients who are recovering are weaned off therapy, but if they're not improving, they are usually continued on the therapy until they can bridge to an allogenic, essentially a stem cell transplant. So that is all I have for you guys today. Any other questions?
I just wanted to answer the question before about reversal of vitamin K deficiency, particularly for Coumadin, not so much for this.
Yeah.
But so if you have someone who is on Coumadin and they have a high INR, who you always have to ask yourself, how bad is their bleeding, and why are they on the Coumadin? So if their bleeding is life-threatening, it's in the CNS, or it's a massive GI bleed, there's no question, you just go ahead and you reverse them. But if it's minor bleeding and they're on the Coumadin, for example, they have an artificial valve, and you're going to reverse them, you may clot that valve. So then you might think, hey, I'm just going to let the Coumadin wear off, and and watch them carefully. And if they start to bleed massively, then I'll reverse it. So that was kind of answering that question, but not for your case.
No.
For what we would do on someone with vitamin K antagonist.
That's great. Yeah. Thank you so much. Kim, go ahead. No, go ahead.
Oh, I was gonna, with HLH.
Yeah.
I was gonna say, it's maybe worth definitely talking with the hematologist or oncologist prior to giving Dex, just because a lot of the time it can be associated with blood malignancies or look the same. And if you give Dex, you may not be able to do that biopsy to get that diagnosis. So don't just give it off the bat without
Absolutely.
Yeah.
That goes with all cancer.
Yeah, generally all cancers or all diagnoses where cancer is high up on your differential, just call your hematologist. You're absolutely right. For the most part, you would probably wait for the ferritin to kind of give you a sense of whether this is more HLH or this is more malignancy anyway, which takes half an hour, 40 minutes, maybe a little bit longer, but definitely. Any other questions?
I was going to say, I like the last course question too. I completely forgot about HLH, but through the process of elimination too, the elevated CRP, this has been going on for 3 weeks and this kid doesn't look more septic appearing. So you're reassured it's not infection. The only thing that fits up with this, obviously inflammatory process is an elevated ferritin. So that's the answer I chose. So process of elimination works too.
Excellent. Yeah, that's the whole point. Yeah. Go ahead, Adam.
The other thing that some hospitals do is they measure natural killer cell activity.
Yeah.
And just double check that you have low or absent natural killer cell activity in your piece of HLH. I've never seen a kid with HLH, at least because I haven't been practicing as long as some people, but whenever we had a kid that came in with that kind of a picture, they were always admitted with fever of unknown origin, presumed sepsis, then HLH was always discovered after the admission. So then that's when they talked to hematology and got all these extra supplemental studies before they started things like Dex and all these other high-risk things. But if that kid comes in with 3 weeks of fever, you're going to put them on antibiotics because you're not.
Maybe, and it's not unreasonable from your ED standpoint if you are unsure to give the antibiotics until the blood culture is negative. I don't think anybody's going to fault you for it, and I don't think it's really going to harm the patient in any way. So I don't think that's unreasonable at all. And I think most of us would do that because we're sort of just like, well, what's going on? This is weird.
And the other random marker is elevated CD25.
Yeah, that's right.
I know that they do as well. There's a lot of really weird heme markers that big children's hospitals are sending almost routinely in HLH patients because they actually they're more rapid than they used to be, and they come back faster.
So I actually remember during COVID in pediatric patient, or MISC, excuse me, in pediatric patient, sort of very similar presentation. So earlier on, when we were sort of still figuring out what was going on, we had sort of talked about sending CD25 and NK cell activity IL-6 and ferritin as part of our MISC workup, because the thought was that the cytokine storm associated with COVID in children, which is now known as MISC, is maybe very similar to MAS or HLH. So I know we sort of, and I think the sort of national consensus is that you probably just do the ferritin, and we've sort of weaned down since, but yeah, it's definitely something that is not uncommon, and we can send it here. It's going to be a send out to, I think it goes to Northwell, but it's not uncommon. And then, yeah, Olivia, go ahead.
Oh, and just an add-on, for the ferritin, the like level will be really high. It'll be like greater than 5,000.
Yeah.
Something like that. So it's not like high as in greater than 100. It's super high.
Super, yeah, it's super, super high. Yeah. That's a, objective fact, super high. All right, if no other questions, one thing I like to do is sometimes you get a lot of information with these presentations. Can we just go around the room? Can someone tell me one fact that they learned about Tephilitis? Go ahead, Jane.
Just like the initial presentation of Tephilitis, I'd never heard of it, like abdominal X-ray findings and stuff like that, and exactly how to treat it.
Perfect. Yeah, that X-ray is not your first line of, you want to antibiotics and you want to do a CT scan and you want to skip your ultrasound. One thing you guys learned about hemophilia.
Give factor right away, don't wait for anything else.
Yep, perfect. What else did we cover? We just talked about mast cell activation, sickle cell, fever. We've beaten this to death, but you can tell this is very important. Anyone? Jack?
You have to look good, go back to your criteria, like have a low threshold to admit the patient to
Yeah.
lapse in or second out.
Yeah, and the other thing is not, go back to your criteria, but really at this level, you should know your criteria for admission. It's just sort of a non-negotiable. You got to know a sick kid as soon as you see it, a temperature more than 40, Y count less than 5, more than 30, someone with prior sepsis, and a drop of their hemoglobin more than 2 is an automatic admission regardless of what they look like. So that's just something that you have to memorize and know. I don't even remember what other topic you covered, but that's great. All right, thank you guys. And no other questions? Anyone? Everyone's good? Perfect. Feel free to email me if you have anything.